Welcome everyone to the TCSA Educational Webinar Series for 2026. We're glad you're all here. Tonight's topic is rehabilitative strategies for tethered cord syndrome. We're joined tonight by 4 amazing physical therapists who are treating and helping patients every day with tethered cord in their own practices and are here tonight to share that knowledge and experience with us. Danielle Jolliff, Stephanie Hall, Amy Morris, and Patricia Stott. Thank you all for being here tonight. I'd like to start with a short introduction to Tethered Cord Support Alliance. Our mission here at the TCSA is to improve medical care and quality of life for everyone with tethered cord syndrome. So everything we do here is focused around that mission. Right now we have multiple different exciting initiatives going on that are designed to help all of you meet your goals. That means no matter who you are, if you're here tonight with us, then our goal is to get those resources and information that you need out to you. So for our webinar and resource library is growing, which is awesome. We're adding new things every month onto that library. And it has actually a lot of really valuable documents already there. You can find recordings of the webinars that we've done already and a long list of other resources. We have an accommodations letter for education, like school, that can be sent to schools to help with 504 plans, a list of different specialists that you might see for tethered cord syndrome. And especially connected to our topic here tonight, there's a bunch of physical therapy reference sheets. We have information for patients, information for physical therapists. There's a pre-op reference guide and some post-op care, other rehabilitation. There's also a really neat list of like modalities, tools, and skills that help physical therapists to treat tethered cord more efficiently. So you can kind of look and see, hey, like what skills am I looking for in a physical therapist, or maybe as a physical therapist, what skills or trainings might be valuable to me as I'm treating these patients. This webinar will also be recorded and added to the library afterwards so that you can watch it later, also on the TCSA YouTube channel, along with other previous webinars. Also, you can see that list there on the slide of upcoming educational webinars. Very exciting. We have some more great presenters coming up. You can register for those through the upcoming events page at tetheredcord.com. Next, our peer support program allows us to connect high quality experienced mentors with people who are new to tethered cord or people who are looking for some extra support with that. This program is really going strong, so if you're interested in getting help, please fill out the form that's linked in the chat. Or if you have patients who might benefit from this program, please direct them our way. You can also send us a message in the chat or email to hello@tetheredcord.com if you want us to send you program cards that you can hand out to patients with an easy QR code for them to sign up for this program, and we can connect them that way. Those program cards also have a QR code for our Tethered Tuesdays group support meetings, which those meet twice a month on the first and third Tuesdays. The first and third Tuesdays are for adults, led by Melanie Ramsey, and twice a month also for the pediatric group. The second Tuesday is for parents, and the fourth Tuesday is our kids meetup, which actually is now facilitated by a couple of very talented high schoolers that have tethered cord syndrome, which that's exciting to me because it lets our kids really connect and learn from each other and other kids their age who share some of the same struggles and also victories. Same for adults. Those meetings are welcoming to everyone. You can come in there and get help with whatever is bothering you, whatever's going on. Very informative, very uplifting experience, and we'd love to have you join us for those anytime. Real quick now, we'd love to get to know everyone in the room a little better. If you wouldn't mind answering a few questions on this poll for us. I just want to know, what brings you here today? Are you a patient, caregiver, or parent, clinician, or are you just looking for more information about tethered cord? Let's see those results coming in. Awesome. Awesome. Thanks, everyone. Okay, it looks like we have a lot of patients here, which is fantastic. I'm excited. We have a lot of, I think, really valuable information for you tonight, as well as some clinicians. So that is wonderful. Thank you. Thank you all for being here. You all of you people that are here in the room tonight are so instrumental to spreading this information and helping us get these great programs up and running. So if you'd like to get involved and contribute to our mission, we'd love to have you join our team. All of us here are volunteering our time to make these programs happen, including web development, our board members, our presenters, they're volunteers too. Everyone else is giving their time to help move this forward. So there are valuable volunteer opportunities here, no matter what your schedule is. So just shoot us a message if there's something you'd like to do, and we'd love to hear from you. It is now my pleasure to introduce Danielle Jolliff, a physical therapist with more than 15 years of clinical experience and a dedicated advocate for individuals living with tethered cord syndrome. Danielle earned her undergraduate degree from Ohio University and her Master of Physical Therapy from Walsh University. Throughout her career, she has pursued extensive advanced training in biomechanics, manual therapy, functional movement taping, myofascial cupping, ACL injury prevention, and connective tissue disorders. Her professional expertise is complemented by lived experience. When her daughter was diagnosed with tethered cord syndrome at age 11, Danielle experienced firsthand the challenges of navigating a rare disease diagnosis, complex treatment decisions, and long-term care. That journey inspired her to establish a physical therapy practice focused on patients with complex conditions, providing the specialized individual care they need to improve function and quality of life. Since joining the Tethered Cord Support Alliance, Danielle has become an invaluable member of our team. She has generously shared her expertise through outreach efforts and the development of educational resources for both patients and rehabilitation professionals, always bringing enthusiasm, compassion, and a genuine commitment to improving lives. Please join me in welcoming Danielle.
Okay. Thank you, everybody, for having me talk today. I really appreciate the opportunity. I'm going to talk a little bit about preoperative physical therapy and where it fits in with tethered cord release surgery and how it can be beneficial. I'm going to spend a few minutes talking about this today, but I want to acknowledge the help I received on this presentation. It was a group effort between Patricia Stott and Susan Chalela, who are also wonderful physical therapists that kind of helped build this document that we have on the webpage. So next. So what is prehabilitation or pre-op physical therapy? Preoperative physical therapy or prehabilitation or prehab is physical therapy that you undergo before you have surgery to get ready for the upcoming surgery and recovery. It's kind of a get your body ready. The goal of the preoperative physical therapy is to get you in the best place that you can while still understanding all of the limitations and current restrictions that are in place. So for tethered cord patients, a key goal is to make sure that the exercises and the movements don't add extra tension to a nervous system that's already under strain from the tethered spinal cord. Recent research really supports personalized rehabilitation programs before major surgery, demonstrating that it can enhance recovery. Next. So how it works. Prehab works by optimizing function, improving baseline core engagement, overall stability and mobility, and can make post-op rehab more effective. It enhances body awareness by learning proper alignment and movement patterns before surgery to make sure that post-op precautions are a little easier to follow. It can also help by reducing anxiety. Becoming familiar with therapeutic exercises and the physical therapy setting can help reduce post-op and pre-op anxiety. And this can be done through pain science education, mindfulness, and other situations that help lower nervous system sensitization pre-surgery. So there are a couple of benefits. One is building core engagement and stability. So these are gentle exercises that prepare the abdominal and back muscles, posterior chain muscles, and muscles all over the body to support the spine while it heals. These are gentle low load exercises that are more of an activation or an engagement, less focused on kind of the bigger movements, more focused on just stabilizing and engaging around the spine, kind of getting those muscles ready to go. Right. Next. Then another benefit is learning some of the post-operative techniques kind of ahead of time. So a great example is log rolling. After surgery, log rolling is a good way to get in and out of bed. It decreases the pain and stress through the spine. Practicing that before surgery can be very beneficial in just building muscle memory, answering any questions that you have about the movement, and allow practice with that movement so you can feel comfortable with it in your post-operative recovery. Other things that we can discuss preoperatively are things like taking your shoes on and off, how to brush your teeth without having to lean forward, different sleeping, lounging, resting positions, and any other personal comfort situations or questions that are unique to your situation. Okay. Another benefit is that it establishes some baseline measurements. This is not an all-encompassing list and not everything will apply to everybody. But before surgery, we can measure kind of your baseline or your starting point so that after surgery, you kind of can have an idea of what has changed. We can measure strength, we can look at gait mechanics, how you're moving, how you're walking, or if you are wheelchair bound or mostly wheelchair dependent, we can look at transfer strategies and how those things are going. We can look at your range of motion, your neurological symptoms, your neural mobility, and any functional mobilities and restrictions that you are having. So these baselines kind of let us know where things are starting so that we can track things as you recover. Few more benefits are improving confidence, reducing anxiety, and giving that continuity of care. So surgery is stressful kind of for the whole support system. So pre-op PT sessions can give patients and families, caregivers, just a place to meet and talk where you can work through some of the things that are questions, concerns. You guys can build a shared plan of how you're going to work through some of the post-operative challenges, some of the pre-operative questions. The important part about this is each plan is different for different patients and different people in different stages of lives. So you want to have a collaboration with your physical therapist where you can shape the approach around your support system, your surgery, your individual needs at the time, right? That continuity of care will then follow you after surgery if you choose to go back to the same physical therapist, because they will know kind of where you started and what things look like, and then that will help as things kind of progress post-operatively on where your abilities were, where they are now, what types of things work well for you. It just makes that process post-operatively a little smoother and continuous. So what does a prehab program include? And again, this is not an exhaustive list. The guiding principle for prehabilitation or pre-op physical therapy should be that you avoid any extra strain on an already tensioned nervous system, right? So these are things that are gentle core engagement exercises, isometric exercises for the core and for the posterior chain, neutral spine type strengthening, engagement, positioning, supported movements using props as you need to for comfort, things that you can do without increasing some of those neurological strain, neurological symptoms, right? It can focus on neural health, pain science education, pain-free neural mobility, such as things like nerve flossing, things to reduce sensitization. You know, manual therapy can be beneficial if you have a physical therapist who is comfortable in some of those techniques. You can do functional movement training. This talk about how am I going to get in and out of bed? How am I going to get in and out of the car? What types of things are going to be the best for me to have at home to get on and off the couch, or if I need any help in the bathroom? Those types of things are good to incorporate into a preoperative program. Preoperative programs are very heavy on education, right? You can talk to your physical therapist about potential post-op precautions, recovery timelines. That's very individualized, but you can have those conversations with your physical therapist, and then just managing post-op or preoperative limitations. Right? You can go over breathing exercises, whether that be diaphragmatic breathing or other gentle breathing techniques that help with relaxation, reducing nervous system tension, reducing stress preoperatively and postoperatively to help move through that recovery process. And then you can discuss things like activity pacing, making sure that you can balance some of your postoperative and preoperative activity with rest to kind of provide a more steady state as we can move through recovery and hopefully reduce maybe some of the ups and downs, although inevitably it's a way to modify those things, not change them entirely. Next. All right, so practical tips to maximize the benefit of any preoperative physical therapy. The first one is to start early, ideally several weeks ahead of your surgery if you have the time. The second is to practice at home. Reinforce what's learned in sessions by practicing those techniques at home. Right? Third is to ask questions. Use sessions to raise concerns, especially for anything that's unique to your particular situation. And four is to create any reference documents. So that might be taking notes, or if you have your therapist's permission, maybe a video of a certain type of technique or exercise that is really helpful, maybe notes or a video on something like log rolling, so you have that as a quick reference for after surgery. Right. And next. Then one of the key parts about preoperative physical therapy is that it really does need to be personalized to you. It's not necessarily a one-size-fits all because everybody's very different. Symptoms are very different. Limitations are very different. So you want a prehab plan that is built to you. You want exercising, pacing, teaching style to match how you learn best. You want programs that are designed to your individual needs. Family and caregivers should be included. Anyone supporting your recovery is welcome into the planning process. When you want to address existing limitations, any current mobility limits or symptoms that can be factored into your program, and you want your particular home environment, your daily routine, your personal comfort, kind of all factored into that plan. That's why it's important. And next, these are my references for my talk today, and I thank everybody for joining.
Thank you so much, Danielle. That was awesome. Really appreciate your insight. And I feel like pre-op physical therapy is one of those aspects of care that gets ignored or overlooked a lot. So we really appreciate your insight here. It is now my pleasure to introduce Stephanie Hall, a doctor of physical therapy whose passion for individualized patient-centered care is evident in everything she does. Stephanie earned her Bachelor of Science in Kinesiology from Boise State University before completing her Doctor of Physical Therapy degree at Rocky Mountain University of Health Professions in 2019. She has completed specialized training in fascial distortion model and pelvic floor therapy and has developed particular expertise in treating bowel, bladder, pelvic pain, and pediatric pelvic floor disorders. One of the things I've come to appreciate most about Stephanie is she's never afraid to take on a challenge or dig to the root of a problem. She's deeply committed to making sure each patient receives the care that is right for their unique circumstances, digging into the latest research, collaborating with colleagues, and thinking creatively to find the best solutions for complex cases. Stephanie's thoughtful, evidence-based approach and personal dedication to her patients make her an outstanding resource for the tethered cord community. We're very pleased to welcome Stephanie Hall.
Okay, so my name's Stephanie. I'm going to be talking specifically about pelvic floor physical therapy in tethered cord. Um, our focus today here is going to be specific pelvic floor, but it's also important to know that during an actual pelvic floor visit, you're still going to be looking at all the other things that all of the other PTs that like are after me and even Danielle talked about. But we're doing specific pelvic floor for this presentation. Why the pelvic floor is affected. Pelvic floor, like symptoms, bowel, bladder, sexual health, is one of the first things that usually changes in tethered cord. It's one of the first things that people actually notice because of the um, specific anatomy and the sacral nerve roots that become compressed in tethered cord. Um, as the spine changes. So, like, especially in pediatric populations, as the spine starts to grow, as the tethering becomes a little bit more noticeable, bowel and bladder function are usually the very first that you'll notice. And so, we'll talk a lot specifically about each one of these: bladder, bowel, sexual function, and then pain. So, bladder dysfunction, the most typical symptoms that you're going to see in tethered cord is urgency, frequency, um, incontinence, hesitancy, incomplete emptying, like not being able to empty your bladder all the way, sitting on the toilet and not being able to get it out. Like it takes a long time for the stream to come, the stream is weak. And then things like incontinence, stress incontinence, urge incontinence, sometimes even like overflow incontinence from the bladder just being too overfull and not having a sensation of that. And then sometimes even recurrent UTIs can be a symptom too, based on the bladder's inability to actually empty properly. When the bladder's not emptying properly, you're at a higher risk for UTI. Bowel dysfunction, we're looking at things like constipation, delayed colonic transit, a reduced rectal sensation, and like an actual urge for a bowel movement will be reduced. And then incontinence also, fecal incontinence, overflow incontinence that comes from bowel also, where the kind of fresher stool just seeps through old hard stool and not being able to sense that that's happening. We'll talk a little bit more about bowel diaries and Bristol stool charts in a little bit. And sexual function, biggest things that you're going to notice here are decreased genital sensations. So nerve roots S2, 3, 4, 5 are going to go straight to also sensation. So genital numbness, um, dyspareunia, which is pain with intercourse, usually coming from a tight pelvic floor. Difficulties with arousal or orgasm, and then in males, it's erectile dysfunction or ejaculatory dysfunctions, and then pelvic pain, tailbone pain, general pelvic pain, pain with intercourse. Important to note that a lot of times people are not going to just automatically give this information up. It takes a lot of cueing and specific questions to really know if you're dealing with this or not. From a pelvic floor perspective, usually you're going to end up with two different types of presentations, either a hypertonic or overactive pelvic floor, or a hypotonic or underactive pelvic floor. Your hypertonic is going to come, or symptoms based on that is going to be your urinary retention, constipation, incomplete emptying. And then your underactive, your hypotonic is going to come with more incontinence, usually erectile dysfunction, and then weakness. It's also important to note that there are some people who will have both of these presentations. They might start out with a hypertonic, overactive pelvic floor, but they also have a weak pelvic floor. In that case, you're going to make sure you treat the hypertonic first, the tight pelvic floor, before you actually start with some strengthening so that you're actually strengthening the entirety of the pelvic floor versus just a partial range. This is a little bit more PT specific here. We've got some outcome measures down here, bowel, bladder, urinary incontinence. There's a men's health specific one, the prostatitis symptom index. The Wexner score is fecal incontinence, and then I also included pain down here, central sensitization inventory, because chronic pain tends to come with pelvic floor dysfunction and just tethered cord in general. And diaries, we're looking at a bladder diary and a bowel diary. Bladder diaries, you're looking for fluid and food intake. You're looking for how urgent was it when they needed to go to the bathroom? How often are they urinating? What type of incontinence is happening? When is the incontinence happening? And same ideas with stool. Stool, you just have a little bit more specific of your Bristol stool chart. So your 1 through 7, what does the stool actually look like? And then fiber intake, having people keep track of their fiber intake. Objective assessments for pelvic floor PT specifically is going to be sensation, dermatomes of S2 through 5. Your anal wink reflex is the main sacral reflex. Also still going to be looking at like deep tendon reflexes though, and then general lower extremity strength, spinal alignment, movement screenings, which I know is going to be covered, I think, a little bit later. So I won't go into any detail there, but also things that you'd be looking at in just a general pelvic floor PT visit. From a pelvic floor muscle exam, you've got an external exam where you're looking at resting tone, you're looking for symmetry. If one side of pelvic floor, like nerve function specifically, isn't working very well, you'll notice a difference in symmetry from side to side. Internal exam, if it's appropriate, either a vaginal or rectal exam to grade pelvic floor strength. We use the standard modified Oxford scale, 0 through 5, 0 being no contraction at all, 1 being like a flicker, barely a contraction at all, 3 being a contraction with no lift, and then 4 to 5 is going to be contraction, like a good contraction with a lift of the perineum. Some other different ways to assess pelvic floor function is going to be EMG, surface EMG. There is also vaginal or rectal, like internal sensors that you can get. Those are just a little bit more expensive, so I don't use those a ton. Otherwise, surface EMG and then anal manometry biofeedback. And then you're looking at different coordination testing of pelvic floor. You're looking at strength, you're looking at tone, especially with an internal exam, you're looking at tone. And then you're looking at contraction, relaxation, the ability to bear down, and then is there some sort of reflexive pelvic floor contraction with coughing? Here's some general precautions for pelvic floor PT. Possible retethering is going to be new or worsening weakness, sensory changes, back pain, and then a decline in your previous, like we had improvement in bowel bladder function, and now all of a sudden it's getting worse again. Definite signs of retethering. And then post-operative precautions, Danielle touched on that earlier. And then just keeping in contact with surgical teams, GI teams, urology teams, dietitians. General PT protocol, assessment, patient education comes in a ton. We'll talk about some of that later. Manual therapy, strengthening, relaxation, and then your functional integration into actual daily activities. Manual therapy techniques, we've got abdominal massage. So we're looking at clockwise strokes following the path of the colon, ascending to transverse to descending colon. Pelvic floor and abdominal wall trigger point release, rectus abdominis, obliques, pelvic floor like levator ani and pubococcygeus. And then also obturator internus and piriformis because of their close proximity to pelvic floor. Some different stretching exercises here. A lot of this is also in the handout that I gave too, so I don't need to go over this too specifically, but here's some like general stretching to work on pelvic floor specifically, to work on all of the muscles around pelvic floor, diaphragmatic breathing to get pelvic floor lengthening. Same thing here, some strengthening exercises. We're looking at specific just pelvic floor contractions. The knack maneuver is a pre-contraction before, like a cough, a sneeze, lifting, Anyone that gets the stress incontinence, this is your bread and butter, the neck maneuver. So making sure that people are doing pelvic floor contractions prior to whatever causes the leakage. And that's something that you should be practicing in clinic. And then some general core and hip strengthening. I've got a little note down here. Pelvic floor works with deep core, your transverse abdominis, and hip external rotators. So obturator internus shares direct fascial connections to the pelvic floor muscles. Obturator internus is a hip external rotators. So we're working a lot on external rotation and even like abduction strength. There's a study mentioned down through here talking about two groups that they have a control group that does nothing, a group that does only pelvic floor strengthening, and then a group that does only hip strengthening. And the pelvic floor strengthening group and the hip strengthening group improved at the same rate in their pelvic floor strength. So even like your people with tethered cord who are going to have a hypotonic pelvic floor from like the poor nerve innervation, if they don't have a very good pelvic floor contraction, even just doing transverse abdominis strengthening and obturator internus and external rotation and general hip strengthening in itself will improve pelvic floor strength, even if you're not directly working pelvic floor. Like I said, lots of patient education that comes with pelvic health. Toileting posture is huge. Normal bladder habits, we're looking at every 2 to 4 hours. If someone is not getting the sensation to urinate very frequently because of poor nerve innervation, they're probably going a lot longer than 4 hours, which is going to cause some bladder dysfunction. It's also going to increase the risk of UTIs. No straining with urination. Normal bowel habits. The norm that they say is 3 times a day to 3 times a week. 3 times a week seems not enough in my opinion. Daily is usually what we're looking for. And then usually your Bristol type 4, which is soft, smooth sausage shape. Fluid intake, we're looking for half your body weight in ounces, and that's probably more specific water intake, not general fluid intake, but water intake, and then adjusted for activity and climate. So you're in a really hot environment, that needs to be higher. You're doing a lot of activity, or your kids doing a lot of activity, that needs to be higher. Fiber intake, the USDA guidelines are 14 grams per 1,000 calories consumed. So standard adult is going to be like 28 to 35 grams of fiber. For an adult female, at least, if we're looking at males, adult males are going to be closer to 40 grams. Kids are going to be maybe more toward 20 to 25. Healthy bladder habits, don't rush, don't strain, don't hold for long periods of time. On the right over here, there's some urge suppression techniques. So when someone is dealing with urge incontinence, fecal or urinary, these will work either way. You want to stop what you're doing, pause, take some deep breaths to kind of calm the nervous system down, do pelvic floor contractions to basically inhibit the urge for bowel or bladder. Once the urge decreases, then calmly walking to the bathroom. And this is taking a better look at toileting posture. Specifically for bowel movements, we're looking for knees above hips, squatty potty, step stool, stack a bunch of books, something to get the feet up so knees are above hips. This is kind of backwards here, but so when we're sitting with just feet flat, the puborectalis is going to tighten, and the anorectal angle is usually like 80 degrees. Compared to when we get our feet up on a step stool, that puborectalis will relax, will lengthen, and anorectal angle will become a little bit straighter. This was an interesting study down through here. Time to empty for bowel movements went from 130 seconds to 51 seconds when using a footstool and when having knees above hips. Some specific habit training, bowel habit training, attempting bowel movements 20 to 30 minutes after meals to help with the gastrocolic reflex. Gastrocolic reflex meaning that every time we eat something, the colon will naturally contract to move everything through to make room for everything else that's coming. That works best first thing in the morning, which is why most people poop about 20 minutes after breakfast. You've got your abdominal massage, like we talked about earlier. Usually, I like to try to do that with especially kiddos and adults 5 to 10 minutes before sitting on the toilet to stimulate the colon. And then working on defecation and bearing down with biofeedback, EMG, manometry, to make sure that pelvic floor is not contracting when bearing down is happening. And then fluid and fiber review on all of your logs. Okay, key takeaways here. Pelvic floor symptoms are directly connected to sacral nerve traction that comes from tethered cord. Your exam is going to have your neuro screen, your standard pelvic floor assessment, and your standard physical therapy assessment through spine mechanics, movement screenings. Treatment is going to depend on presentation, hypertonic versus hypotonic. Make sure you're always, if they have both, if they're hypertonic but also weak, dealing with hypertonic first before strengthening. And then some of our precautions, neurogenic changes. If something seems a little off, sending them back. Because chances are whatever you're doing may not help us. That's all I got. Thank you.
Okay, thank you so much, Stephanie. Yeah, I really appreciate it. So moving right along, I'm very excited now to introduce our next speaker, Amy Morris. Amy is a physical therapist with more than 30 years of experience and a nationally recognized educator in the treatment of complex musculoskeletal and connective tissue disorders. Amy is the owner of Amisa Therapeutics in Langhorne, Pennsylvania, and earned her Master of Science in Physical Therapy from Thomas Jefferson University. Throughout her career, she has pursued extensive advanced training in manual therapy, craniosacral therapy, neurovascular and visceral manipulation, the Schroth method for scoliosis, postural restoration, Pilates, yoga, and nutritional physical therapy. In addition to her clinical practice, Amy is a continuing education instructor developing courses that help rehabilitation professionals better recognize and treat connective tissue disorders and abdominal vascular compression syndromes. She also collaborates on the development of non-surgical treatment protocols for these complex conditions. Amy is an active participant in the EDS ECHO professional education program, where she engages in ongoing case-based collaboration with international experts in connective tissue disorders. She also holds advanced certifications in scoliosis rehabilitation, including Barcelona, Schroth, and SEAS, and regularly participates in the Society on Scoliosis, Orthopedic and Rehabilitation Treatments International Congress, and other spine-focused educational programs. Amy specializes in helping patients who have not found relief through traditional approaches, combining deep understanding of structure, movement, and function to improve posture, spinal alignment, and overall quality of life. We're all very excited to welcome Amy Morris.
All right. That work? Are you seeing me change the slides? Okay, great. All right, then let me go back. Okay, here's why it matters for pain specifically. Tension does not stay in one place and it travels. It goes up towards your head and neck, and it can affect our autonomic nervous system function. It goes through to the spine, causing pain and stiffness, goes through to the hips and legs and even the feet, and systemically, will affect bowel and bladder, as we just heard, and can create sensory changes. This is important because tethering is a tension problem, not just a structural one, and tension can be worked with, and that's the whole idea behind the strategies that I would want to talk about for back pain. In addition, many of you are also managing hypermobility comorbidities, including Chiari, POTS, craniosacral instability. And these conditions often all happen together. So if your symptoms feel like they involve more than just your back, that's not in your head. It's why care needs to be layered and coordinated across several conditions, and not just focused on one of those conditions. Most of you have already probably been through the workup with the history and the exam and the imaging and additional testing. So this is familiar ground for you, so I won't go through all of that. And as a reminder, not every problem that you have is due to your tethered cord. So we can be getting mechanical strain and overuse and muscle aches and pains that happen to everyone. So tether cord is definitely going to be contributing to all of that and maybe causing most of your symptoms, but you don't have to attribute every symptom to that diagnosis. And if you've been through the workup, and as the previous presenters have mentioned, you want to make sure you know what the red flags are. The main thing I'll say is if you notice worsening of any symptoms, then you need to follow up with your care team and make sure that they're being addressed. Right, so on to scoliosis. So for those of you who have been managing scoliosis, the theory is that the growing spine outpaces a cord that is tethered and creates uneven tension and contributes to the curve developing. Let's be clear that not everyone with tethered cord syndrome has scoliosis, and not all scoliosis is related to tethered cord, but for some, it is connected. And then pain can happen alone with tethered cord syndrome without scoliosis. So if you notice that you have pain that is worse with bending forward, sitting for too long, certain positions, that's a very common pattern with tethering. It's not, something you're imagining, and it's definitely not because of deconditioning. It's a mechanical response to the tension in your cord and your nerves. And understanding that connection is usually the bridge in our for that understanding will reduce the stress and anxiety about the pain. And certain positions and movements can provoke pain, then they can also help reduce that pain. So let's talk about what actually helps when we have pain. While there's no cure for tethered cord syndrome besides untethering, many people experience meaningful improvement in their symptoms and function with the right support and management. And so I'm going to go a little bit out of order in my list here, but the first thing here is education. And that's why everybody's here, is to understand understand how to get the care that you need and have optimal function. Inflammation, tension, the nervous system, and your symptoms itself, understanding all of that is a treatment tool. And when you understand, it's easier to respond strategically rather than simply enduring or panicking when you have a new symptom. So I'm going to talk about some of these bullet points in a minute, but let's talk about manual therapy. Manual therapy, when appropriate, can really help reduce some of our muscle guarding, tissue stiffness that develops when the body is compensating for the chronic neural tension. And then some advanced manual therapy techniques like craniosacral, myofascial, neural, and vascular techniques that Patty and I have both trained in often can very much help when people are having increased pain. Then there's breathing optimization. That's a really powerful tool, very helpful with pelvic floor symptoms as well. Our diaphragm helps regulate pressure. It helps with our posture stabilization and circulation and autonomic function. So improving diaphragmatic breathing also reduces whole body tension and autonomic and sympathetic overdrive, and can help improve our neurological and nervous system regulation. And nervous system regulation is much more than just relaxing, because tethering puts the nervous system under persistent strain. Gentle movement, pacing, and stress reduction can directly reduce nervous system irritability and improve the resilience of the nervous system. Chronic stress and elevated cortisol levels increase your inflammation and make nerves more sensitive. And in some cases, I find that some physicians will actually recommend medication aimed at reducing inflammation and calming nerve sensitivity when appropriate, which often helps manage the symptoms. So let's just take another minute to talk about how inflammation plays a role. They reinforce each other. Mechanical tension on the nervous system increases the irritation and the neuroinflammation, and then that makes the nerves more sensitive, and it becomes this feedback loop. And it creates a cycle. And then that leads to muscle guarding and increased tension, and then other symptoms that can continue to get worse. Because of this, reducing your inflammation may actually reduce how reactive and sensitive your nervous system feels, and even if the other underlying tension has not actually changed. And for some people, that means exploring anti-inflammatory lifestyle approaches, which includes identifying food sensitivities, emphasizing more nutrient-dense anti-inflammatory eating patterns, making sure you optimize sleep, that's really important, considering supplements when appropriate that might reduce inflammation. You want to reduce your exposure to environmental triggers that consistently worsen symptoms, such as fragrances or chemicals or sensory irritants if people are sensitive and susceptible to those items. And then there's movement retraining. For many people, this is one of the biggest impacts. Sustained positions that increase tension on that spinal cord often worsen the symptoms. And this may include prolonged slumped sitting, sitting cross-legged, spending hours bent over your laptop or your phone, remaining in one position for too long. And small changes do matter. Supportive seating, taking movement breaks every 20 to 30 minutes, and finding sleeping positions that avoid sustained flexion can make a meaningful difference. At this point, I do want to also say that if there is a scoliosis, working with someone who is trained in scoliosis, helping you find postures and positions that will help support your curve and not progress that curve. That's a very unique thing for each person, so I don't really feel comfortable giving specific advice here, but knowing that decompressing as much as you can and aligning the spine as neutral as possible can often make a big difference in people's pain. And then lifestyle support really matters. As I mentioned, sleep, hydration was already mentioned, super important. Nutrition, making sure you take recovery time when you have activity and reducing your exposure to triggers that worsen symptoms and can influence how much reserve your nervous system has available to manage your baseline tension. No, please note that none of these interventions untether your spinal cord, but they can reduce the amount of inflammation and tension that your nervous system is carrying and improve how your body responds to stress. And for many people, that translates into meaningful improvement in pain, function, and resilience. You're not powerless, and you don't have to navigate this alone. That's what the support group is about. And I often say to my clients, it's the 10% rule. If you do one thing and it improves things 10%, that may not be very meaningful for you. But if you do five things and everything helps you by 10%, that's very impactful. So what I want to leave you with is your pain and your scoliosis is influenced by more than just your spine. Your whole system plays a role. Understanding why you respond and will help you be more effective in managing it and not just enduring. And conservative everyday strategies, movement, breathing, knowing what positions decompress and reduce tension, and nervous system support genuinely add up. Using things that help like PEMF mats, frequency specific microcurrent, anything that can help reduce inflammation in our nervous system the impact can add up and make a big difference. And once you have more influence on how you feel, then you might be able to have a better strategy for if you choose to have surgery, prehabbing, and post-rehab. And having this support group is probably one of the best ways that you guys can do that. And that's it.
Okay, thank you so much, Amy. I loved this presentation. It's very encouraging. Like I come away with, we can do this, guys.
Yeah.
We can do this. So thank you so much. And now we get to introduce Patricia Stott, a physical therapist, educator, and internationally recognized leader in the care of individuals with hypermobility spectrum disorders, Ehlers-Danlos syndrome, and tethered cord syndrome. Patty is the owner of Elevation Wellness in Colorado, where she specializes in treating individuals with complex connective tissue and neurovascular conditions, including upper cervical instability, vascular compressions, autonomic dysfunction, and spinal cord tethering. Drawing an extensive background in orthopedics and advanced training in neural, visceral, and vascular manipulation, fascial counterstrain, craniofacial therapies, and functional medicine, she is dedicated to helping patients who have not found success through traditional rehabilitation approaches. Beyond her clinical practice, Patty is deeply committed to advancing education and improving care for this patient population. She develops continuing education programs for rehabilitation professionals, has authored several books on hypermobility disorders and their coexisting conditions, contributed to peer-reviewed publications on EDS, upper cervical instability, and tethered cord syndrome, and serves as a leader in professional education through the EDS ECHO program and International Consortium. What makes Patty especially remarkable is her incredible energy and unwavering commitment to this community. She always seems to be leading multiple initiatives at once, whether educating clinicians, contributing to research, mentoring colleagues, or advocating for patients. As someone who personally lives with both hypermobility and tethered cord syndrome, she brings not only exceptional clinical expertise, but also genuine insight into the challenges patients face every day. We're honored to have you here to share your knowledge and experience with us. Warm welcome to Patricia J. Stott.
Thanks, Rebecca. I'm going to share my screen. I hope.
That's better than I did, I hope.
Working great.
Okay, I think we're good, guys. All right, so I came on first to talk about modalities for tethered cord. I could probably fill days of talking about tethered cord. So I had to throw something extra in. So I just wanted to, as the last speaker tonight, kind of review the overall approach that we have, or I'm hoping we will have in the future for tethered cord syndrome, whether it's standard, occult, acquired. So we're going to go over kind of the general physical therapy concepts really quick. I know I don't have a lot of time because I know there's also a lot of learning in the question piece. And then I want to talk about just two of the bigger modalities that I hear come up in this population and review some of the information on that. Let's see. So I do believe that this might be in one of those handouts of how to find a physical therapist. I think that it kind of reviews these 5 approaches that we want to make sure that we're reviewing with an individual that has tethered cord syndrome. So like as a physical therapist, I might not be able to fill all of these roles for an individual. That's why like referrals are amazing. I am not a pelvic health specialist, but I have people to refer my individuals to. That's why creating our networks is really important. And our patients also give us really good feedback. I have learned everything from my patients. They give me the names of providers, the names of these modalities that we'll be talking about, and the things that I now specialize in. So these 5 things, I do find that we're going to have more success if we at least make sure that we're checking in with the patient to see how much they might need from us or another provider in each of these categories. So safe movement, education, body mechanics, self-care, we've kind of talked about that, I think, across all of these different presenters that have been going on so far. The monitoring for systemic inflammation and heightened neural sensitivity. We've talked a little bit about neural sensitivity in a couple of the lectures as central sensitization. Amy brought up the systemic inflammation. This is really important. Restoring neurodynamic mobility is, I think, underrated, and I don't think that we use it yet enough as we should in the future. So I think that's whether it's manual therapy or teaching the patient, nerve glides, nerve flossing in a safe space is important. Neurological retraining has to do with that central sensitization piece, that hyperreactive nervous system that happens because of this constant mechanical traction feeding back that Amy talked about, the feedback loop. And then reestablishing neuromuscular control over the affected muscle groups, which are typically in that posterior chain. So I have all of this on the slides. It's what I'm going to run through these very quickly. Some of it's already been covered. I did check and make sure you guys should have all the access access to the slides. So I'm just going to run through these quick, and then we're going to get to the modalities, because I know that people are always asking questions about that as well. What can work for me? What do you use? But education we've covered already a little bit, I feel like, but let's not forget ambulatory aids are something also that we might have to work with individuals, whether it's a cane or even a wheelchair. This is something that we can either evaluate for or refer out for as physical therapists. So this is something definitely to ask your therapist if you're a patient. We talked about those prolonged positions. Your therapist can teach you how to avoid these positions, how to put some slack on the nervous system, and to support those spinal curves appropriately. The systemic inflammation and heightened neural activity, I think when you're in the moment and having a flare-up, it's really hard to tell, is this me progressively going downhill or is this just a flare-up? So having somebody be able to check in with your body, kind of keep an external look at what's going on and give you that recommendation of, hey, it's time to go back, or I think that we can manage this or try these few things before you decide to go back, is really, really helpful. And it can actually help settle the nervous system as well. The neurodynamic mobility, these different things to restore neural movement is something that we can help with, not curative, because there are other things contributing to tethered cord. It's actually quite complicated. Finding somebody that can work on whether it's teaching the individual nerve flossing, nerve gliding, teaching them how to move their sacrum or to do hip hinging, which is a strategy to reduce tension on the spine as we bend over. Different manual therapies, and I think that Amy touched on this, fascial counterstrain. Burrell Institute teaches neuromeningeal manipulation and brain manipulation, which I've found very helpful. Lymphatic specialists that work around neurological tissues. I'm not a lymphatic specialist, but I've referred out and I've had success with this with patients as well, in at least relieving some symptoms. And then we'll talk a little bit more about some of those tools and modalities. The neurological retraining, this is huge. I haven't met an individual that has a version of tethered cord that doesn't have some spectrum of central sensitization, and we can be more involved or less involved. There's a ton of different things, and this is where it almost becomes more confusing. So working with a provider is really helpful. People get really excited and they're like, oh my gosh, I have all these things to try. What's going to work for me? And we're like, I don't know. You have to try these. There's, an infinite number of possibilities of how to restore the autonomics, how to retrain the nervous system. And I list a few here. There are brain retraining programs, DNRS, Gupta, Primal Trust are some of those out there. There's transcranial magnetic stimulation, neurofeedback, pain reprocessing theory, just general happiness, hope work. And then we have all these ANS strategies for the autonomic nervous system that we can do, whether it's physical ones or passive ones, like cranial nerve or vagal nerve stim can be really helpful. And so many, many more. When we talk about strengthening, we have to make sure that we're regaining the control of the muscles before we start strengthening. And that's where, because the nerve being traction and stretched and not getting very good nutrition in those areas, and the nerve tissue, especially around the phylum, is changing. It's just not getting the healthy signals from the spinal cord out to the muscles. So we have to make sure that we're improving the control of the muscles before we go into exercise and strengthening. And physical therapists should be able to help with that. But again, we just might have to remind our physical therapy team that this is a neurological presentation before it's orthopedic. So we might have to think neuromuscular control, get the muscles responding appropriately first before we move into that strengthening and exercise that we stereotypically think of in physical therapy. Okay, so let's come back to the tools. I know that everybody always has questions about this, and I am sorry, but we are going to fly through this because I want to make sure that we get to the questions as well. And to be completely honest, I am not a specialist in shockwave therapy. I've done the research on it for different projects. I think it's fascinating. I can tell you, and I do see a high volume of tethered cord patients. It's between 25 and 50% of my patient population, and I'm in the clinic 5 days a week. So I have a lot of feedback from individuals. I have had people try shockwave therapy, and providers give me really good feedback. And then I have a handful that it just doesn't seem to work for. And that's where trial and error is. I understand it's financially draining. It's mentally and emotionally exhausting, but hopefully we can find the right match in some of these tools for individuals. Shockwave therapy does seem to help with individuals who have experienced spinal cord injury. So references are on here for any interested. It does seem to help with muscle spasticity, walking ability, bladder function, quality of life reports, and independence in individuals' daily tasks. So it does seem to be helpful. What it is, it's a type of acoustic wave, so a sound wave. It's in the same family of ultrasound and radio pulses, but it is not radial shockwave therapy. That is different. They have completely different wave characteristics in them. It can be delivered through whether it's water, magnet, or through the skin. The delivery can be a little bit different, but the type of wave is very specific. It works both on the intra and extracellular matrix, so the connective tissue, and that's what we think is hopefully happening around the spine. It's stimulating some sort of regeneration in a positive way. Like a lot of our pharmaceuticals, these tools are something that we're seeing the results and we see what happens, but we're not quite sure how it's happening yet. So what you'll see a lot of these are reporting is the positive outcomes, but we don't necessarily know exactly how it's happening. But it does work on these inflammatory mediators, and it can help stimulate new blood vessel growth. Okay, so it has been linked to tissue repair, both in bone and tendon. This is the most important part of what I will say today, and we'll talk about this a little bit more with frequency-specific microcurrent. This is actually from the article. This is quoted from the article, "Appropriate education is key to outcomes and success." This is really, really important. The education, and we run into this problem with microcurrent, you really need to know why you are treating somebody to be able to deliver the appropriate treatment to them. With shockwave therapy, with microcurrent, you need to know the why. So I'm just putting that out there. That's the website that's on here. You can click on that and it should take you to the website that allows you to search in your area to see who's been trained and certified in shockwave therapy. It is something like microcurrent that providers can get their hands on and not have training in. So I've gone through training for microcurrent. Amy has as well, actually. We find it very beneficial. It is a type of electrical modality that can be used therapeutically to address targeted tissues. So the way it works is that you typically have two different frequencies running. Every tissue in the body has a certain frequency. It's the same between all individuals. And then the pathogens or the reasons for these pathological issues are happening all have their own frequencies as well. So you put those two frequencies on and you address general inflammation happening at the spinal cord. And you can make kind of like an algebra equation. You can figure out how to treat somebody in knowing why they are dealing with a tethered cord. And that's why this is so important. I know that there's been some talk out there about individuals that are nervous that this stimulates the spinal cord. It does not stimulate the spinal cord. Are there some frequencies that can increase the activity of certain cellular mechanisms and things like that? Yes, I usually stay away from those, but microcurrent is about 1,000 times less amperage than a standard TENS unit. This is not stimulation. This is trying to regain a baseline and balance in certain tissues. Okay, there are, again, like 1 or 2 studies that are out there that do say that it can help reduce neurological adhesions and reduce cytokine activity after spinal trauma, which is inflammation that happens around neurological tissue. Okay, so understanding FSM, so how to use it, and then connective tissue pathologies combined. And I'm not even talking about connective tissue disorders. I know there's some people here that are probably like, I don't have EDS. This is growing in people with EDS because it is actually affecting the neurological tissue. And those with connective tissue disorders are just more prone to that happening, especially when inflammation becomes the problem. So I am not putting these numbers out there to give anybody an idea that they're going to go pick up their machine, they're going to put these on there, and they're just going to run these protocols. This is to possibly take back to your provider for some information. Like I said, you really need to kind of go back and forth with somebody to figure out what the appropriate settings for you are. I have my basics, I modify them sometimes for individuals. We talk about this tethered cord protocol that's available for microcurrent, and the one that I learned in taking the course is really this 1310, 13443. And like I said, we have a frequency A that works on the pathology and frequency B that works on the tissue. So I don't want to teach everybody how to use this, but 1310 is adhesion of the cord, 13443 is adhesion of the dura. And that's how we kind of program this in. And this is kind of the standard approach that you'll see in somebody using tethered cord, is to work on inflammation, to work on adhesion, okay? And they do recommend that on this, we're talking about possibly regaining some neural mobility back, right? Because we're reducing adhesions. You put it on for 20 minutes, and then the patient is encouraged to work on movement. So nerve glides, nerve flossing, spinal movement potentially with it. However, again, it's important to know why somebody has an issue, right? So I'll show you my protocol and the why behind it and the why I changed the protocol for my patients. But if somebody has this occulter acquired tethered cord that seems to be overlapping with multiple other conditions and can be very much driven symptomatically by inflammation, we also need to be working on inflammation and the immune system on this great device, right? So this is my base tether cord protocol that I've adapted and changed. Because for those with tethered cord, it is not just an adhesion and it's not just inflammation, it's a mechanical traction that over time actually changes the biomechanical properties of the tissue and turns it more into a tendon-like stiff material rather than that pliable spinal cord that we are supposed to have. So from experience, I felt this. So I thought I need something other. It's so stiff. So what these are on channel A is histamine. So one of those mediators, the code for inflammation, tension, nerve trauma tension, congestion, scar and fibrosis, hardening inflammation, sclerosis, and adhesion and scarring. That to me is kind of the basics of what's getting at the tissue changes, not just things being stuck in place, but the chronic change of the tissue over time. And then in mine, I go into, the tissues that are addressed are spinal cord, dura, peripheral nerve, sacral plexus, cauda equina, lower spine, fascia, and skin. And then I throw one in just for fun to calm down the areas, just spasm of the fascia to hopefully calm things down. So take this to your provider. I don't claim that you have to get permission from me. If you're a provider, please use it. I purposely don't have times on here. The providers are probably like, hey, what times are you using? I actually adapt. I have a long one that's about 6 hours long for somebody to wear. I have a medium one and then a short one as well, because there are people that do not tolerate this. It sounds magical, right? But there are people that do not tolerate this, and that's typically with uncontrolled inflammation, which is a talk for another day. But just like everything, it's not a one size fits all. These are great. They work for people, but just not for everybody, and we have to get the timing right as well. Okay, so that's my tethered cord protocol. Please keep it. These are some of the devices. So this is what I use in office personally. There are other devices out there. The one on the left is a direct current device. The direct current device, this is the few $1,000 one, right? And this is why it took me a while to get into this. But that one, is the direct current. We call it like more bang for your buck. You'll usually feel things happening a little bit quicker. However, the one on the right is a programmable PEMF device, or pulsed electromagnetic frequency. It changes the microcurrent into pulse magnetics. So it works well, and it's actually usually more comfortable for people. You don't have to use sticky pads, but it usually takes a little bit more time for it to work. We talked about kind of that neuroimmune component, or that inflammation driver that people have. So these devices have, on this one in particular, autonomic nervous system settings. So those are, I do like one of the generic ones that are on there. Vagal tone, relax and balance, they work great. 81-109 secretion of the vagus nerve, almost having like a little bit of a vagal stim device. General inflammation, immune support, concussion, and vagus are all, I call them generic. They're great, but you'll usually see them on devices. they're usually very great to run in tandem with tethered cord protocols. And then anything based on the brain, because we know it's pulling down, that brainstem is being pulled down into the cranial base, and that doesn't feel good after a while. So anything brain-based that the provider might have for you, hindbrain, midbrain, forebrain, and medulla, are also kind of ones that we get taught right away, and are part of the initial education as well. Okay. I know I talked fast. Thank you so much. And I probably went over my time, but thank you all for listening. That is me a couple weeks ago, summiting Pikes Peak, and I'm headed to Kilimanjaro next week. So things can change for people. It just takes a lot of work in finding the right people. And that's why I'm so excited to be here with all of you guys, because I don't think there's enough information getting out for people really to understand how much help is out there, although it takes a little bit of puppeteering to figure out how to collaborate with multiple providers.
All right. Thank you so much, Patty. Thanks to all of you guys, Danielle, Stephanie, Amy, Patty. When Rebecca and I were first talking about the need for a webinar like this was beyond my wildest dreams, the information presented today. And I thank everybody who attended and who answered or who filled out some questions. So that's what we're going to get to now. We have about 15 minutes to go over some quick questions. So these will both be from the registration, and some people have already found it. You can use the Q&A feature in Zoom to submit your questions, and we will get through as many as possible. Rebecca mentioned it earlier. My name is Melanie Ramsey. Not only am I the vice president of the TCSA, but I facilitate the adult support group, and I am also an adult with tethered cord. So I was getting emotional today at all the hope that was offered today. So let's start, and anybody can jump in at any time. Let's start with one that's a little bit more generic. So what can be done when the body reacts with increased spasticity during physical therapy exercises? And we can expand this just to whether that's pain or, yeah, we can start with that one, and anybody can join in at any time.
I can start off. I mean, that's usually a sign, right, that we're in a hyperreactive nervous system state and like neural tissue state. So either whatever's going on for the patient is too much for the nervous system. So switching to more of like an autonomic focus type of treatment session would be really helpful. But also remember there's anatomy involved. So are we in a neurally tensed position? So taking somebody out of that slump position, making sure that they're supported for their spinal curves, and providing slack. So that's why going to a therapist that knows like nerve flossing, especially, like how do we put slack on the nervous system to relax this posterior chain? Those are the two biggest ones I'd say is just getting to recovery, because I think one of the biggest things, and I don't know if we touched on, is the biggest things in physical therapy is you never push through with this population. You're never trying to do more the next day. You're only trying to meet them exactly where they are that day. And that's where, like Amy said, the 10% rule. It's actually, I tell people it's 10%, but it's on a scale of 1,000. But but after a while, you start to see the changes and shifts. So reduce neural tension, get into a neural slacked position if possible, and then see if we can do some autonomic calming, which is like a world of different therapeutic strategies.
All right. Thank you. And again, anybody can join in. So this one, you kind of spoke about this. So what common signs or symptoms do you see in your clinics that would trigger you to question whether an undiagnosed patient might have tethered cord? And then it's kind of a two-part. What recommendations do you have for physical therapists when they see this in a patient? So someone who's presenting with tethered cord signs that you know about, but they might not know about.
I think there might be a little bit of a clinical difference between pediatrics and adults. So I don't know if somebody wants to start with a little bit of a pediatric presentation of what we see, and I'm happy to comment on the adult.
I don't do peds, so I can't help you with that. But I mean, I think Patty mentioned it, having a really good network of people to refer to is key. And I think we already talked about, like, if their pain is worse when they're slumping, if like all the neural tension, those are red flags for it. But having good referrals and validating the patient is always where I'm at, is trying to figure out why and do we need further testing. But also trying to keep the fear low, because you can go down a rabbit hole and people start freaking out.
Good referrals. Hear that.
I
This
can
is sort of,
I
oh
can
yeah, go ahead.
answer more specifically. I'm going to cheat. I might be reading something that might be published by the end of the year. Okay, so hang in there, guys. So, for physical therapists or like for anybody really, any history of progression of symptoms neurologically, history of toe walking as a child, also as an adult, history of scoliosis in children or changes in spinal curvature in adulthood. Possibly a sacral dimple, which is an indentation at the base of the spine, right above the crease of the buttocks. Symptom progression after mechanical impact or viral disease. So those inflammatory type of triggers. The symptoms that we'll see are leg fatigue, weakness, or heaviness, leg paresthesias, pain in the sacrum, back, legs, or the perineum or the saddle area of the pelvis. Bladder symptoms include all of it: leaking urgency, frequency, hesitation, retention, pain during urination, or history of urinary infections. Bowel symptoms are obstipation, which is severe constipation, bowel incontinence, and sexual dysfunction. And then there will eventually be, if I can run off this quick, physical therapy examination should be spinal alignment and postural assessment, gait assessment, appropriate neural tension testing, assessment of sacral nutation during hip hinge. I know this is scientific, guys, but for our PTs out there to record it, that would be great. Lower extremity reflex testing, clonus testing, so that rhythmical beat at the feet, muscular testing, looking at neuromuscular recruitment, not on muscle strength, that is not associated. Looking for the sacral dimples, pelvic floor assessment, if appropriate, in the scope of practice, and a diaphragm assessment. So anything that comes back that starts to match multiple different groups is when we are going to refer out to our specialists. And I know what everybody's thinking. Who? And I know it's really tough. That's why I like having a group like this, and we can start understanding like who's in what areas. I have my people. We actually have somebody in Colorado Springs that doesn't do surgery, but will at least investigate. So it's growing slowly.
Thanks, Patty. This is sort of related to Danielle, what you talked about, which is prehab, which is how often do you see prehab offered and spoken about with clinicians? And do you see that covered by insurance often?
So how often I see it as far as clinicians and with patients? Basically never. It's kind of one of those things where in the orthopedic setting, I see it all the time. I did a ton of my career in pre-op physical therapy for post-op or for total knees and total hips, right? And that was really common. But for the tethered cord community, I don't see it at all. As far as the insurance base, insurance typically covers preoperative physical therapy just like any other physical therapy. It's not a difference in how the insurance covers it.
Okay. Does anyone else want to speak about? Have you seen prehab offered to any of your patients or the clinics? I know it's definitely something we need to be fighting for a little bit more, for sure. In my experience, the physical therapy is offered to prove the tethered cord diagnosis because you need to fail physical therapy before they'll look further and give you an MRI. So, thank you, Karen, for that question. This is a little bit similar about the FSM devices. I mean, I know you can't make specific recommendations, but where is a trusted source to purchase those? And again, how do we get those covered by insurance, if at all?
They are not covered by insurance yet.
Nope.
And to purchase them, you actually have to be a licensed provider for the direct current machine. So Inspirastar, Mend, and Precision Care are the main models. However, what I tell my patients, if you happen to be on eBay and you find a model that I have the software for, please go ahead. And sometimes in these groups, right? They're like, hey, I'm done with this. I'm going to get a new device, or I'm going to go to magnetic converter. Who wants my old machine? You can get it for hopefully a cheaper price. But yeah, I don't know, right? The knowing who knows how to program. I've heard some horror stories this week already, and it's only Tuesday, about prices charged for even trying one protocol. Um, I don't know how to answer the question on how to know. Hopefully, we'll have a training out there at some point for tethered cord and frequency specific microcurrent.
I appreciate that answer. Thank you. Yeah, and that's what we're here to do, right? Is to like wave our flag and let people know what we need. Stephanie, this might be a little bit more in your wheelhouse too. So we had a question basically about someone who has recurring bowel obstructions due to an existing hernia. So how can they support their physical therapy without overdoing it and then like honor both of those conditions, basically?
Yeah, I did see that question. The other thing that was mentioned in that question was a lot of major abdominal surgeries. So,
Yes.
like,
And
especially
yeah,
from a bowel obstruction standpoint, like making sure that we're working on scar tissue. And then from the hernia, anything that's not flaring up symptoms is fine by me. Any sort of transverse abdominis, any abdominal bracing, training, stuff like that. Sometimes from a physical therapy perspective, you can just palpate where that hernia is, and if you can feel it, they start doing their abdominal contractions and then like some more intense movements. If you feel that hernia popping out a little bit more, you know they're not ready for that yet. The sequence of where to go and how far to progress, I think is going to be based on that, based on is the hernia getting any worse that you can feel, is pain present, stuff like that. But starting really basic, if the hernia symptoms aren't getting any worse, do whatever that person can tolerate.
okay, thank you for that. And again, we're just trying to get through as many of these as possible. Um, Amy, this one, since you talked about scoliosis earlier, we had a question here. Oh, and it just disappeared for me.
Sorry, I answered one. It might have been.
Oh, oh, that might have been it. That might have been it. Oh, yeah. So does kyphosis fit into the scoliosis diagnosis? Patty answered it, but I know Amy spoke about that in your presentation, so I don't know if you have an answer for that. You want to speak to that a little bit?
Kyphosis is a one plane spinal curve where scoliosis is in three dimensions. So they're both spinal. Well, kyphosis is everybody should have a kyphosis. It's hyperkyphosis.
Okay.
That's the problem. We're supposed to have a small upper back curve. So it does fall within, if it gets excessive, more of a spinal malalignment. But it's not specific necessarily to tethered cord. But you do see it.
And it might be more, well, we usually see more of a scoliosis, like a typical scoliosis presentation in children and adolescents, where because of the growing spine, however, we might see more of a kyphosis type of change in our adult population for accommodation. So,
And I think that in my experience that I've seen a lot of people who had adolescent idiopathic scoliosis that I believe it was tethered cord all along. You know, when they're standing in my office and I'm seeing certain patterns, but try and get a doctor to do further testing because if you have a diagnosis of scoliosis, everything's because of your scoliosis. I have somebody with MS. I'm sure she's got a tethered cord and no one will look at her because she has MS. So they attribute every symptom to her MS.
Yeah, that one laser focus on getting one diagnosis and then we're not going to look any further. Again, it's part of my personal story as well, so I really appreciate you speaking to that. All right, we only have a few more minutes left. I wanted to get to one more that was from the pre-registration questions, and we have a lot of great questions here in the chat. We won't get to all of them, but keep coming back, everyone. And again, look at our resource page with these handouts and documents from tonight. There's a lot of great information in there. Can you talk about central sensitization as it may be caused by tethered cord and any treatments for this complication? Again, for everybody.
that is like a whole nother night.
Yeah.
It's impossible.
I threw some in there and talked very fast. But pain neuroscience education is something that we talk about in physical therapy a lot. Anything for autonomic rebalancing or retraining. All of the neural retraining programs. So you can even consider neurofeedback and transcranial magnetic stimulation part of this, along with DNRS, Gupta, and primal trust programs. Cranial nerve stimulators for people that might have central sensitization can be helpful. Vagal nerve stimulators. Yeah, even the diaphragmatic work that I think maybe everybody has talked about today. It sounds so simple, but actually correcting diaphragmatic dysfunction can help regulate the nervous system. Our exhale is a parasympathetic stabilizer, and a lot of us are missing our exhales. So, anything else? I know I'm missing infinity numbers of things.
I mean, I have to say, like sometimes I just have people put on binaural beat relaxation, closure, like it's free. Put it on your headphones, close your eyes, and breathe. Or go for a walk out in nature. Like that is, as long as it's not going to flare your symptoms, it's so regulating. And for me, it's very effective.
And I think it was brought up too, the lifestyle changes, which is a super big talk. But if you're somebody that has a more reactive and a struggling nervous system, anatomically, inflammatory wise, like programming, whatever it might be, if your job is too much for your nervous system, you got to talk about it. If your relationships are affecting your nervous system, we have to talk about it. So it can also include these big lifestyle modification talks that are very difficult to have, but over time can be part of the bigger healing process.
And trauma, history of trauma, childhood trauma, forget about it. Like that's something people don't even want to talk about in a session. I'm sure with Stephanie with doing pelvic floor, she sees that all the time. It's a big burden for people.
Yeah, and I'll throw that in there with trauma because of it actually causes neurological inflammation, which the spinal cord needs no more of with tethered cord. Is that an article just came out on autism as well, and the body's ability to handle neurological inflammation specifically. And they're not able to do it even compared to individuals that experience psychosis in the general population. So I think understanding the neural diversity and understanding how to support your nervous system if it is different is also extremely important, but a long conversation.
Agreed. All right, we're almost close to our time, and I'll just say this, that's one of the reasons why our support groups also exist is it's not just talking about tethered cord in a clinical setting, it's talking about that childhood medical neglect, trauma, fill in the blank, and like we have a safe space for that. So if you're listening tonight and you feel like you want some more support in that, yes, look at our resources, but stop by one of our Tuesday day or night support groups, and we can talk more about it with, again, other people who get it. I'm gonna finish with one question that I think is just gonna be hopeful. And I think everybody can kind of talk to this a little bit if you feel like it. It says, is 1 to 3 years, and fill in the blank of years, post TCSA surgery too late to do PT? We already know the answer to this, right? It's never too late. But if you guys want to offer like a things that you've seen improvements or, lifelong physical therapy to help. We've talked about the lifestyle things. We'll end with that. And I thank everyone again for their participation.
My opinion, it's never too late. I've got people I've been seeing for 15 years and just supporting them.
Personally, my daughter is 2 years post-op, and we are still going with PT and still seeing good improvements in a lot of the manual therapy stuff, especially.
Yeah, I do a lot of conservative care management, and that typically takes 1 to 3 years. If those are looking for non-operative, it's typically our mild to moderate presentations, but even post-surgically, the retethering piece, there's so much, and I think you'll see, hopefully, we have publication on the way out in teaching people the missing pieces. We're going to start providing better care for our patients because there has been a lot of gaps.
That sounds good, everybody. All right. We went a minute or two over. I just want to give one last push. If you enjoyed the program that you saw today and you would like to support our programs in general, we just want you to know that we are 100% volunteer staffed. Everyone here is donating their time. And so how you can help us is getting involved in our program. So you can request resources for your local hospital or clinics. We have printouts now, flyers, business cards you can bring and let people know what tethered cord is and the work we're doing. We're always seeking grant opportunities, and please let us, inform us if you have sponsorship opportunities, corporate giving programs at your job. We'd love to hear about those and what you're doing right now, attending, volunteering, and participating in our events. You can find everything that we talked about today on our website, and you can also scan that QR code to donate to our cause. So I want to thank Rebecca as well, Smith, for helping me host this webinar. And this was beyond our wildest dreams. And we have tons more in the hopper. So thank you guys so much. And we will see you next time.